I'll I'll talk a little bit about what the neuropath core does and what kind of brain tissue and other specimens we have, and give you some examples of studies that we have supported recently. So the neuropath core and the brain bank is primarily responsible for participating in brain donation autopsies, where we dissect brain tissue for diagnosis and also for banking. We provide the neuropathological diagnosis for the family and also clinicians, and also we curate this in our database. We also do long-term storage of brain tissue, including both fresh frozen brain tissue and formalin fixed. We also have postmortem CSF and some DNA that we have banked associated with these samples. So we maintain a database with the clinical data and the neuropathology information. And we are, like all brain banks, we also distribute tissue for neurodegenerative research, both at Duke-UNC and also internationally. We occasionally ship tissue to like Australia, UK, and we have in that way established collaborations worldwide. So to get all this brain tissue into our bank requires collaboration with a large team. There are the clinical coordinators that recruit and maintain a relationship with the participants. There is the hospital team, including the decedent care and autopsy team that handles the transportation and the logistics of when the participant passes. And then finally, the piece that we come in is we come in during the autopsy to take the fixed tissue for neuropathology diagnosis and CSF and frozen tissue for biorepository. So for a lot of these resources to be able to get to our hands really involves like a lot of people in this process, and most importantly for the participants' families, who are really a lot of them are really eager, really motivated to to donate this brain tissue, even when they are still in the grieving process. So I'm going to show you a little bit of the gross pictures and a little bit of neuropathology, just as a way for introducing everyone to the basic neuropathology. So as I said, at the time of autopsy, we split the brain in half, and half of it is sliced fresh. The other half is put into formalin for 10 to 14 days, and that allows us to make really accurate dissections for neuropathology diagnosis. And as I said, basically there are several regions that we routinely take, about 15 blocks that we take, and these will be put into these plastic cassettes and go to the histology lab, where they will cut 5 or 7 micrometer sections and do various staining to allow me to reach a diagnosis. The reason that we take all of these sections is really based on what we understand about how these different pathologies spread. So, for instance, AD is characterized by plaques and neurofibrillary tangles, and they have a different pattern of spreading. So the plaques, they start in the neocortex, then they spread into from the frontal end to the occipital end of the neocortex, and then into the hippocampus, amygdala, basal ganglia, and then lastly to the brainstem and cerebellum. Whereas the neurofibrillary tangles, they start from the locus coeruleus in the pons, they spread to the entorhinal cortex and the hippocampus, then to the frontal cortex, and lastly to the occipital lobe. And notice that the cerebellum is almost never involved with neurofibrillary tangles in AD. The Lewy bodies follow a similar spreading propagation pattern as in neurofibrillary tangles, first starting in the brainstem and then going all the way to the neocortex. And so most brain banks can take anywhere from 15 to even like 20 or 30 sections to try to capture all of these different pathologies. And I think I try to strike a balance between like giving an accurate diagnosis and leaving enough tissue to distribute to investigators. Because if you put everything, submit like too many sections to get a diagnosis, then you don't have as much tissue left to distribute to other investigators. So my balance is 12 to 15 sections, and I feel like that way I can already capture almost all the different diagnoses. So, so I'm just showing you a couple of pictures about the common brain pathologies that we see. So plaques are characterized by immunostaining for amyloid beta, and they come in many different flavors. So some of them are the dense core plaques. These are considered the mature plaques where there is a core in the middle mixed with dystrophic neurites, and surrounding the plaque there could be a lot of microglial macrophages, which we can't see in this type of staining. Then there's also plaques that are more diffuse, and they can often be seen in like the subpial regions or sometimes in the white matter in the cerebellum as well. So they lack a circular structure, they lack a core in the middle. And also amyloid can also deposit in the vessels. And we often see that in the older population. This is called cerebral amyloid angiopathy. It predisposes them to brain hemorrhages. Then for the neurofibrillary tangles, we use tau immunostaining. And this specific tau is phosphorylated at specific epitopes. So these are not the normal tau that we see in normal brain function, but rather phosphorylated tau that will detach from microtubules and form aggregates. And they are these intracellular structures in neurons. And there's also other methods to look at plaques. So these are the dense core plaques or the neuritic plaques that I talked about. So, so the gold standard is to do silver stain. The silver stain is very expensive and very finicky. There's a lot of variation between the technicians. So we've adopted thioflavin, which is a organic dye that stains the tissue, and then we use a fluorescent microscope to look at the dense cores. So for instance, this is the core of the neuritic plaque that will light up when we do the thioflavin staining. And of course, there is a lot of overlap with AD and PD, as well as dementia with Lewy bodies. These we capture with immunostaining for alpha-synuclein. There's also a lot of overlap between AD and late, which is limbic predominant TDP-43 pathology. And this is captured by immunostaining for TDP-43. So TDP-43 is normally a nuclear protein. And in these disorders, they translocate. So for instance, this is a nucleus of a neuron. So the TDP-43, instead of localizing in the nucleus, it has moved away and become sequestered in these cytoplasmic inclusions. So that's what you often see. Same as here, we have the nucleus is clear, free of TDP-43 staining, and with adjacent cytoplasm is filled with a TDP-43 inclusion. Sometimes you also see TDP-43 inclusions in the nucleus, or sometimes they can also form these like tangle-like structures adjacent to the nucleus. Also, we carefully categorize the different types of vascular pathology, as well as strokes, infarcts, hemorrhage, and all that. Then there are occasionally we do get these rare tauopathies. For instance, we have a few cases of corticobasal degeneration, and those are characterized by tau, not in the neurons, but in astrocytes. So this is called the astrocytic plaque. We also have about 20 cases of PSP, progressive supranuclear palsy. And this is another tauopathy that is characterized by tau accumulation in astrocytes. And the morphology here is a little bit different, whereas in cortical basal degeneration, the tau is accumulated in the distal processes. In PSP, it's accumulated surrounding the nucleus and more in the proximal astrocytic processes. So this is a sample neuropathology report that I often give out. So very in the aging brain, it is very rare to have like a pure AD or a pure PD. Often there is a mixed pathology. So we record a different staging for each different pathology that we encounter. And then this is these are the fresh frozen tissues that John, who's my very skillful lab manager, goes in and he slices the brain fresh and he freezes them into -80 right away. And so in the brain bank, we have about 1,100 brains, over 400 CSF samples, and 6,200 DNA samples. And this is just a rough count. We have 750 brains with AD and related dementias, 250 brains with other neurological disorders, and 200 normal controls. So this is quite a valuable resource, especially for normal controls. And the controls are actually the most often what highly sought after tissue. That's what a lot of banks don't have. And so these are some of the studies that we conducted over in the past 4 or 5 years. Some of them are more like conventional clinical neuropathological correlation analyses. Like for instance, when this categorization of late came out, we looked at the clinical and the neuropathological characteristics of late. And later on, we were invited to participate in this larger consortium study, which basically is a collection of data from 13 different community-based cohorts, and where we definitively determined the frequency of late across different AD pathological severities. There's also other studies that we could do. This is a study in collaboration with Bin Shu at NCCU, where we're trying to develop site-specific phospho-tau epitopes as biomarkers. But we in addition to providing the brain tissue and CSF for testing, we also did immunostaining for these various different phospho-tau antibodies. We were able to do whole site scanning, whole site imaging, and either use machine learning based analysis software or just by quantifying the pixel, coming up with an unbiased measure of tau burden in different brain regions. We'll also have a lot of frozen brain tissue, which we have supported multi-omic studies over the years. And most recently, this is a collaboration with UCSF, where we were able to profile all of the major cell types, including endothelial cells, smooth muscle cells, parasites, and we were able to even segregate the brain endothelial cells into different subclasses, the venous, arterial, or the capillary endothelial cells. Once the brain tissue has been quickly frozen in -80, it could last very long. We have people using tissue that's been banked for 20, 30 years, and they still get very good RNA quality and able to support this type of research. So I will stop here and acknowledge my co-directors, Carol Colton, collaborators Todd Cohen over at UNC, and John Urban and Aaron, who are at the neuropathology core. And the brain bank is located in the Bryan building, second floor. That's where all the tissue is kept.
There it is. It is a huge resource. Let's see if any of the either folks outside of Duke or the junior investigator crew have any thoughts or questions, or sort of how-tos for accessing.
And I just want to add that you could also go to the same link, investigator resources, to access the NeuroPath core resources. We also have an ARENA web page where you could browse what kind of samples we have, what kind of diagnosis. But I'm always happy to provide any consultation. Sometimes because the diagnosis can be a little difficult to understand, and I'm always happy to help you select the best tissue.
I guess, Jerry, one question I would have is around, for studies where, there's some reason to select a certain, tissue from a specific brain region, but maybe it isn't, there's sort of a cost benefit analysis in terms of availability and accessibility versus having the exact sort of tissue that one wants. I wonder if you could sort of speak to, what gets requested a lot, and then like on the other side of that, what there's probably more of and more easy access to. Like, I know the hippocampus is typically like, in high demand.
Right. Yeah, that's a great question. So typically, people who study AD wants to start with hippocampus and entorhinal cortex. People who study PD, DLB want substantia nigra. So those tissue are highly sought after. Just keep in mind that just because these brain regions are hit really early in the disease process, so by the time that the person dies, these brain regions are really most of the time are already very severely affected, and so it may not be the most beneficial or the best area to study. On the other hand, the human cortex is huge. So if you're interested in like the dorsolateral frontal cortex or really anywhere in the cortex, we could usually provide a lot of tissue, a good selection of cases.
And then could you just talk a little bit about, because it'll differ, I suppose, from site to site, but I believe there's a standard like approved MTA.
Yes, so we do have a standard MTA. So basically, so the MTA is pretty easy to execute unless like the partner institution has some edits. Then it goes back and forth a little bit. Otherwise, it's a very standard.
And for folks internal to Duke, do you still do an MTA, or do you end up adding them to like a master IRB? I suppose that would be kind of burdensome.
Right. So so there we for Duke investigators, we don't need an MTA.
Okay.
There is, and also for Duke investigators, there is an IRB that basically just says that we provide the identified tissue. And so it's for people who have, like in departments where maybe there's, CRU, and really hard to get an IRB. we have some ways to help them out. I just want to add that because we are a shared resource and a core facility of Duke, so there is a price associated with each sample. But the price is not zero. I think it's pretty reasonable.
And then I guess sort of similarly to our sort of conversation earlier about you know, budgeting and those things. You know, if somebody's thinking of putting in a grant where they want to leverage you know, biosamples from the resource, what's sort of the best way to go in terms of having them, you know, query the arena gateway, get some things in mind about what may and may not be available, and then, you know, have a meeting, or, you know, in advance of their sort of grant write-up? What would you sort of suggest as the you know, lowest friction approach?
Right. I suggest that just go into the resource request and request for a meeting, and I could and then we could talk about like what kind of samples we have, what is feasible, what is not, and we don't really need to get in. So we don't, unless you are ready to submit a formal resource, a formal request. Otherwise, we don't really, you know, we don't really provide like quote. I don't charge for my consultation time, and usually it doesn't take that much time. Usually it's like a 30 minutes to 1 hour, and that's usually enough to clarify what kind of tissue is available, what is feasible.
Perfect.